Welcome, everyone. I'm Krista Lamb, and I'll be your host today. IHSTS and the Type 2 Diabetes Network, which does its work throughout the province, would like to acknowledge that we are living and working with humility and respect on the traditional territories of the First Nations people of British Columbia. To start our event today, I'll pass the microphone to the director of the Type 2 Diabetes Network, Edward Smith Griffiths.
Thanks, Krista. And thank you, everyone else, for joining us today. My name's Ed Smith. I'm the director of the Type 2 Diabetes Network, operated by the Institute for Health System Transformation and Sustainability, or IHSTS. As you may or may not know, IHSTS is a small NGO based in British Columbia. Over the past couple of years, the Institute has focused a lot of effort on developing a Type 2 diabetes strategy. We now have a Type 2 Diabetes Network that is up and running. The focus of the network has been on Type 2 diabetes education and understanding the ramifications of the social determinants of health. And it has a huge impact on our work. The Type 2 Diabetes Network is connected nationally, and I look forward to continually expanding the potential of the network. It's with great pleasure today that I introduce Krista Lamb. She'll be moderating the session. Krista Lamb is a science communicator who specializes in translating complex topics into interesting and understandable stories for diverse audiences. Her first book, Beyond Banting, was released in 2021 and went on to win the Science Writers and Communicators of Canada Book Award. In addition, Krista has been the producer and host of multiple podcasts, including the award-winning Diabetes Canada podcast and How to Talk About Health. In 2025, she received a King Charles III Coronation Medal from the Royal Canadian Institute for Science in recognition of her commitment to fostering science culture in Canada. So I'll turn this over to Krista, and she'll introduce our speaker for today. Thanks very much.
Thank you. Thank you for that kind introduction. So to begin, I'll let everyone in our audience know that we have a special format for these events. We call it a vodcast or a video podcast. So there won't be any PowerPoint presentations, and you're welcome to watch or listen or both to our conversation. We also highly encourage people to ask questions in the chat box during our interview, as we'll have a discussion afterward with our guests. We want this to be as interactive and helpful as possible for those who are watching now or in the future. So if there's a burning question that you have, please ask it. And now let me introduce our guest today, Dr. David Campbell, who is an endocrinologist and an associate professor at the University of Calgary. David and his team have been leading research projects that look at how the social determinants of health impact people living with diabetes, in particular around the areas of homelessness and food insecurity. I am lucky enough to know David very well, and I've had the pleasure of talking to him many times, so this will be a wonderful conversation for me as we get to catch up a little bit on his work, and I hope that you will find it as interesting. So David, I will give you the floor to introduce yourself and tell us a little bit more about who you are and what you do.
Yeah, thanks, Krista, and thanks for having me today. It's a pleasure to be here with you. As Krista mentioned, I practice clinically as an endocrinologist, so that's a specialist in hormones and metabolism, and I see people with all types of hormonal disorders, but have a focus on people living with diabetes, both type 1 and type 2 diabetes, adults specifically. In my work, seeing people living with diabetes, I have primarily an outpatient practice. So I see people in the community who are living at home and coming for clinic visits. But I also have the opportunity to work in our hospital system and provide consultative services to people who are visiting our emergency departments and admitted to our hospital services. And they can be admitted for any type of reason, but I see a lot of people admitted to hospital for blood sugar related issues, usually high blood sugars. And over the years, I came to see that there is a pattern in the types of people that we frequently see for these types of inpatient encounters. And when we talk about these, we talk about them sometimes, and the scientific word is ambulatory care sensitive hospitalization, which means really this is a hospitalization that never should have happened, that in the ideal situation, this person's issues, their diabetes in many cases, or their blood pressure, or those other types of things should be dealt with at home. And they should be able to deal with it with a doctor and a nurse and a team helping them from the outside of the hospital. But as soon as they come into hospital, it's kind of like, we can fix this in the hospital, but we shouldn't have to. And the types of people that have those admissions seem to follow along a very clear pattern. And the types of people that we see, and especially recurrently over and over again, are people who face social challenges, so sociostructural disadvantage, as we call it sometimes. So this is not just somebody living with diabetes, but it's somebody who's dealing with food insecurity or housing instability or living with domestic violence or facing the consequences of colonialism or racism or some other structural factors. And when those things are layered on top of the challenge of living with diabetes, it results in them having complications that land them at our hospital doorstep. And so this interested me for a long time, and I said, you know what, I want to learn a little bit more about this. And I started studying this whole phenomenon of the intersection of diabetes with social disadvantage. And that's really the focus of my program of research. So I work closely with people who are have experience living with homelessness, but I also work in other areas of social disadvantage as well, and been able to work in this space for about 10 years now, trying to unpack what it's like to really live with these complex network of challenges.
And one of the things that I find really interesting about your work is that we often think about medicine as like a one-on-one contact. So one touch, you meet one person, you treat one person at a time, but you're really looking at the structural inequities and the systemic barriers. And why is it important with this type of work to look at those things?
Yeah, absolutely, Krista. I mean, they're clearly interrelated and linked. And I learn about structures and systems by talking to people. But when you talk to enough people, you can start to see patterns that emerge in the data. And I think one of the risks with the kind of clinical paradigm of medicine or the one-on-one paradigm is you see a patient and you say, well, this person has this issue, and so I can help this person. And you get really focused on how you can help one individual. But if you don't take a step back and say, that person had this problem. They had a hard time managing their blood sugars because they didn't have a home and they had nowhere to store their insulin, or they couldn't afford their medications because they don't have insurance. But you help that person, maybe as a clinician, sometimes I help my patients by giving them samples of medication that I have, or little sample cards from the pharmaceutical industry. And I can go about my day and feel like I did good by that patient and I helped them. But if you don't ask the question of, well, how many people are there out there like this person who can't afford their drugs? And I maybe helped one, but I didn't help the other 10 or 20 or 30,000 who are facing the same challenges. And I think that's really where we can do more good is, stretching beyond just the one-on-one clinical encounters to think about the policy impacts and the things that we could advocate for to address those inequities for everybody involved, not just the person sitting in front of us.
And one of the really interesting thing about the populations that you often serve is that they're sometimes the ones that face the most stigma. And this series that we've been doing with the Type 2 Diabetes Network of late has really been about stigma and inequities. And this population often faces that stigma even from their healthcare providers. And so I wondered what you have learned in terms of how the healthcare system might need to confront some of these biases in order to improve overall care.
Yeah, that's a great question, Krista. And we know that people who live with conditions like diabetes specifically, are face stigma everywhere they go. It's in their own personal social lives where their friends and family don't understand or don't have a clue what they live with, and so they encounter stigma there. People blame them for their condition. They blame them for the complications that result from their condition, and people internalize that, and that's what becomes stigma, is this constant blame that people are facing. And as you said, I think it's one thing for that type of stigma to emanate from or to originate from, let's call it the uninformed, lay people, friends, family, those things. It's unfortunate that happens, but it's understandable because we all make assumptions about things we don't know about, right? I think that's just human nature. But what I find particularly troublesome is when people encounter stigmatizing experiences from the healthcare system. And the reason I find that particularly bothersome is because we should know better and we should do better, right? When you've been trained and licensed to work as a doctor, nurse, pharmacist, dietitian, you name it, you know more than the general public about these conditions, and you know, and you should know, that living with diabetes is not uniquely the fault of the individual, that there are genetic, environmental, social factors that lead to the incidence of chronic diseases like diabetes, and also that really predict, and the strongest predictors of the outcomes of living with diabetes are those social factors. And so the fact that we in the healthcare world perpetuate stigma is particularly bothersome. And I think patients internalize it more as well because they also expect more from us, right? I think it's easy for many of the patients that I speak to kind of slough off judgmental comments made by, their aunt or their uncle or their crazy grandpa. But when a stigmatizing comment is made by someone on their healthcare team, that has a particularly strong impact on people's lives and on their perception of themselves. And so I think that's why it's just important for us to realize as healthcare providers the impact that we have on patients' lives, and to think really carefully before each interaction, and to make sure that we're not perpetuating those stigmas. And I think that's part of a big part of my research program is really trying to educate and sensitize healthcare providers about these stigmas that exist, so that we can try to eliminate them from our practice and make our places of work and the places where patients come to seek care a really trauma-informed place where we recognize the challenges people face and we don't make them worse.
And those are really such important things. And one of the things I talk about, and I tell the story of meeting you many times, anyone who's seen my talks knows that I talk about your work a lot. And one of the reasons was that you have taught me so much in terms of working with people who are perhaps coming from a place where they're encountering barriers or difficulty, and the importance of incorporating them into the work and not making assumptions. Because I remember when you first told me way back when you were doing your PhD that you were going to have, people experiencing homelessness, living with diabetes, that were kind of come to a focus group and they were going to do this. And I kind of was like, well, don't, I feel like they've got so many other things that are more important than being in a focus group. And you were like, well, I won't know until I ask them, which was a huge learning for me and has informed my life moving forward. And you, of course, now have this incredible group of people who have informed the work that you have done because you did ask them and they were very, very excited to be involved. And so I would love for you to talk about how people with lived experience have helped shape the work that you do.
Yeah, absolutely, Krista. As you're kind of alluding to, the type of research that I do, I mean, I do lots of different research, but the type of research I'm most passionate about is sometimes characterized as community-based participatory research, or CBPR. And what that means is that we take our direction, and the types of things that we study and how we study them and what we're going to do all comes from people with lived experience. And so, typically in academic research, the research question and the methodology and the study design are all things that are created by scientists. And we like to, we've gone to school for a long time and gotten PhDs, and we all think we know how to design a study, and we do. But sometimes we don't design the right study. And that's kind of what we've realized, that when it's just scientists making up studies, sometimes our questions are off. Sometimes the questions we ask aren't the things that are most important or could be most impactful for the people living with the condition. Whereas when we actually turn the research enterprise on its head and we go to the community and we say, what do you guys think we should study? What is your priority in this? Then we can make sure that we're asking the right questions. And it goes beyond that, not just what questions should we ask, but how should we do it? And sometimes they come up with things that we never would have thought of in terms of methodological approaches, right? So, I mean, I can tell the story of Low here, Krista. I made a movie with my group in the last few years to illustrate these stories of stigma and the experiences they had. And the genesis of that is that they started telling us about all these traumatizing and stigmatizing experiences that they'd experienced in their life. And we reflected back to them and said, well, what do you want to do about that? What would be your ideal situation be? How could we address this? And they very clearly said, well, we want more people to know. We want to increase the awareness of what it's like to be in my shoes. I would love for everybody I interact with to understand what it's like to have to worry about your blood sugars while you're dealing with trying to find a home, while you're trying to find food to eat, when you don't have any insulin to inject because it's stored in a fridge somewhere in a shelter and you can't get access to it. All these daily things that happen to people that most people are completely oblivious to. And they said, we want more people to know. And we said, well, how are we going to get people to know about that? And what things can we do? And, as a scientist, I said, well, we can write papers and we can give presentations. And, clearly they said, well, that's not going to really reach the people we really want to get this. We're not trying to tell other scientists about our struggles. We want the people who work in the shelter. We want the people who are paramedics and first responders and citizens walking past us on the sidewalk. Those are the people we want to reach. And so we came up with the idea to initially put on a play. And our co-researchers, these people with lived experience, my group of experts, they were the actors, and they acted in the film to kind of reenact the stigmas that they had experienced in their life for a group of community members who came. And both the actors, the co-researchers themselves, as well as the people who attended, found it to be a really eye-opening, enlightening experience, and wanted to share it more broadly with everybody. And that's why one of our group members said, well, more people need to see this. And we talked about how do we take this theater production on the road, and how do we show this broadly across Canada? And somebody said, well, you could make a movie. Why don't we make a movie about this? And so that was their idea. And we said, yeah, let's make a movie, because that's what you want to do. And that's what community-based research is all about, is elevating the voice of the community, and us as researchers, academic scientists, trying to help them accomplish their goals. And so we made a film. And it's been tremendously successful. We've won awards, but more importantly, we've been able to show it in shelters and hospitals across Canada, and everybody who's seen it has been touched by the stories that have been told. And that's an example of a methodology, an approach that never would have been taken if it was just me sitting in my ivory tower academic lab thinking about what science should I do. And a lot of people say, well, that's not even science at all, but it's been the most impactful science I've ever done.
And it is, and it's a really brilliant movie. And I, once again, you blew my expectations out of the water, because when your researcher friend says, I'm going to make a movie about my research, you don't tend to be as optimistic about it as you might want to be, being a supportive friend. But it's such a brilliant movie, and it's because there's such heart to it, but also it's really well made. You had a film company that made it, and they did extraordinary work. So I think something to be very proud of. And coming from a science communications background and teaching science communications to the next generation of scientists, it's really lovely to see these opportunities to take the research outside of the lab and outside of the publication and outside of the things that other people not in the academic world would never experience. I recently had to explain what a journal club was to a group of people, and I realized that we speak academia in a way that we're often not familiar with. And so you also did something that I wanted to highlight, which is Home Sweet Homeless, which is the first sort of thing that sort of predated Low, which was, again, using the opinions of people with lived experience as to how to tell those stories. And so I wanted to give you the opportunity to talk a little bit about Home Sweet Homeless as well.
Yeah, thanks, Krista. Happy to talk about that, because yeah, that's really where this all started. That was my first foray into the world of community-based research. And the story is similar, that we realized that we wanted to do a project where we could elevate the voices of lived experience folks, and we had no idea where that's going to go. And what I always like to say when I reflect on this type of research is it's often scary for academic researchers, right? As scientists, we're taught from the earliest days that good science is controlled. We need a controlled experimental setting where you as the scientist can make sure there's no confounders, and you design your experiment carefully, even dating back to middle school science fair experiments. That's what we're always taught about science. And so community-based research is outside of that paradigm, where you as the scientist are ceding the control of where this work goes and what you end up doing. And so it's a little bit scary and nerve-wracking, because you say to this group of people who in most cases are lay people that don't have scientific training, and you say, what should we study? How should we study this? What do you want us to do? And you don't know what's going to come back. And you're at that point bound to do what they tell you to do, right? Because that's part of the unspoken contract that you have with them. And in this case, it was our first group of people with lived experience of diabetes and homelessness. We were in Toronto, and we started meeting with them saying, what are we going to study? Again, my own biases and the hat that I wear as a health services researcher, I was hoping and counting on them saying, well, we need to improve the access to diabetes doctors, right? And it's totally a inflated sense of self-importance that, like, well, clearly I can fix these people's issue as a diabetes doctor, and they just need more of me. That was not what they needed. And they told us very clearly that the biggest thing they needed was better access to good food. Diabetes doctor be damned, like, you're way down the road. Things will be way better for us if we could just eat better, and if people provided us with healthier food. And that was the first kind of revelation of, like, well, I really don't know what's important here. And so we went, they told us that was important, and we did an exercise to kind of assess those opinions and those priorities. And it was very strong that was this group's collective priority. And we said to them, well, how are we going to fix this? Like, what things could we do? And again, it was desire to share their experience and their thought that if people could see what we see, they might change their minds, right? It's easy for people who have their own home, buy their own groceries, in many cases have enough means to just assume we can do better. Like go buy healthier food. If you live with diabetes and you're homeless, well, just don't eat in the shelter, go buy food. There's all kinds of things that people can say. And they said, we want to show people what it's like to be in our shoes. And the way they chose to do that was by taking photographs. And so it's a methodology called photo voice, where people were given cameras and we trained them. We brought in a professional photographer to kind of teach people how to compose and take nice images. And people went off with these cameras we gave them and took pictures for a couple weeks, anything that related to diabetes and homelessness, specifically as it pertained to food. And we got all these wonderful images, well, wonderful and horrifying images back of the cooking facilities that are provided, of the food that's given to them when they go to the food bank and get a food hamper, of the meals that are served in shelters, vending machines serving pop and chips in the shelter environment, all these things that just really bring to light the experience of what it's like to be there on the ground. And once we had those images, and we could help them, and we encourage them to debrief and kind of describe the image and what it means to them in their own words. And we put together a photo exhibit that had both the images and the narratives that were created by this reflection exercise. And it was really quite poignant. And we were able to share it across the country at conferences and in shopping malls and hospitals. And to this day, I've had several people come up to me and say, I've been going to diabetes conferences for decades. And the only thing that's ever stood out to me that I remember, a year later, was those photos and the stories of the people who told them. So again, this is, a project that I was there to facilitate, but it was really the community's project. And it was really amazing to see how them with their stories were far more effective at helping people develop an understanding than we could ever be with our epidemiological science or, randomized trials or anything, just elevating people's voices and experience.
Yeah, I know the first time I saw it, it's such a gut punch because you realize that we've been talking intellectually about how food in a shelter system is not necessarily that great. But then when you see the plate of food that the person receives, there's such a visceral reaction to that. So it really is brilliant. And I'm so glad that it's had the impact. It also brings up something that you research as well, which is food insecurity and some of the work that you've been doing in that area. And so I wanted to ask you a little bit about how thinking around food insecurity has found its way into your research. Because you're right, when we talk about diabetes, especially with type 2 diabetes, it's always just, well, eat better or eat differently. That's not always something that's easy to do.
Yeah. Yeah, you're absolutely right, Krista. Food insecurity is such a huge part of this. But even then, I think there's a lot of great scientists doing work in the food insecurity space right now. But usually when we speak about it, it's fairly academic, right? People assess food insecurity using a validated, standardized questionnaire, and we see stats like, 24% of Canadians experience food insecurity, and that's risen from 15%. So we get these statistical numbers, right? And that's quite shocking. 1 in 4 people in our communities can't afford to eat well, right? And if you think about all the people that we interact with, that's a lot of people. So statistics have their role. But it's quite different in terms of the impact that it can have on you as a consumer of the science, of somebody who's reading that statistic to say, yeah, 1 in 4 people can't afford good food, as opposed to reading somebody's actual firsthand narrative and seeing a picture of what the food that they can access is like. I'm convinced that type of work has a different effect on people's brains and really does a lot more to generate empathy and understanding of people of different people's circumstance than statistics. And so I think we need both, and we need the epidemiology for sure. We need people studying the numbers, but we need people telling the stories and people willing to share their experience. And I think that's really what changes hearts and minds and helps us to think and is going to help us ultimately get buy-in from policymakers who are the ones who need to fix this, right? The solution to food insecurity is not it's not rocket science. We need to give people more money so they can afford better food. But we know politically it's hard to generate the desire to make those changes. And I think the one thing that can really help with that is elevating people's voice and giving them a platform to share their stories that we can all relate to.
Yeah, absolutely. Another area, and I think this sort of relates to this that you do some work in, is coordinated care. I learned a lot from you about the need for us to not only provide services to people who are experiencing homelessness, but to provide those services in a way that is accessible to them so that they are not getting a referral for 6 weeks later to go see the foot specialist, but to have the foot specialist on hand. Can you tell us a little bit about the sort of work that you're doing in that area?
Yeah, absolutely. I don't have the quote right up at hand, but there was a famous study published 30, 40 years ago now by early health services researchers who said that the evidence of access to health services is not just essentially an open door policy, but you actually need to look at the utilization and who is using those services. And so it's easy for us in Canada to often just say, well, we have hospitals, we have clinics, we have foot doctors, we have eye doctors. So anybody in Canada has access, should be able to go get stuff done. And most of us, if you have Canadian residency or citizenship in a province, then you don't have to pay for medical care anyway, right? So seeing doctors. And so it's easy for people to say, yeah, well, we have health insurance and we have hospitals and doctors' offices. So if people aren't going, it's their own fault. But I think we have to think beyond that and realize that if there are certain groups or subsets of the population that are not accessing certain types of care, it's probably because they don't have access, or we haven't structured the services in a way that is reasonable for them to get to. And that's very much the case with diabetes, right? I think your listeners probably know very well that, caring for diabetes isn't just about all the things you have to do on your own end. So all the self-management pieces, the diet, the exercise, the blood sugar checks, the medication, but you need a healthcare team. And it's not just one doctor, right? There are some conditions where it's like, yes, I go to my family doctor, they give me the pill and I go and treat my hypertension, for example. Or my, depression in some ways is like that. But diabetes is not like that, right? We need family doctors who are a cornerstone of this. But some people with really complex diabetes need to see a specialist like myself. Many people need to see a diabetes educator or a nurse or a dietitian who can help them with, managing the titration of their insulin, helping them figure out what are those meals and what's the proper number of calories and carbohydrates I need to eat. So the team starts to grow, and then you realize once people start to have eye complications or foot complications or kidney issues or heart issues, the team grows even more and more. So it's not uncommon for some of the people that I see to be connected to 7 or 8 different healthcare providers just for their diabetes. That doesn't even consider the fact that they often live with other conditions too that are unrelated to diabetes. And so if you think about as you said, the coordination, the planning, the executive function that's required to make that happen, to schedule it, to call, to book appointments, to make sure it gets in your calendar. They're all things that are higher order functions that when people are dealing with lots of other challenges in their life, we talked about things already about homelessness. Where am I going to get food to feed my family today? I'm working 2 or 3 jobs to be able to, avoid homelessness or to keep my family fed. Those types of challenges, it's almost impossible to get to all those other diabetes related things and all those visits. And so, usually those things go by the wayside. And there's good evidence to say that people that face these social disadvantages are less likely to have a connection to a regular family doctor. They're less likely to ever see a specialist, even if they need it. They're less likely to get their eyes checked and their kidneys checked. And so therefore they're more likely to present at later stages where they need to have laser treatments on their eyes or they're at risk of going blind. They're more likely to require dialysis or kidney transplantation. There's lots of reasons for that, but one of the reasons for that is that we have not structured care in a way that's accessible for many folks. And so I'm quite passionate in saying that, that's an issue that we can and should do better on, right? That's within our locus of control as a healthcare system, healthcare workers, healthcare researchers. So we need to pivot and reorient. And I always say that the way our healthcare systems are structured, it suits me well, right? I go to my clinic and people come to me, and if they don't come, well, too bad. I just write patient with a no-show, send them back to their family doctor, and leave me alone, which is easy for me, right? There's no sweat off my back. Ideally, people show up and I can bill for their visit, but if they don't, I'm on to the next person. But who it's not tailored for is for people, and especially for people that live with challenging situations. And we need to think about how do we make care easier for them to access. And the whole paradigm of a colleague from the States, Victor Montori, who speaks about the idea of minimally disruptive medicine and structuring our care in a way that can incorporate in people's lives much easier.
And one of the things that you've done is you've, piloted a clinic where we had the resources on hand. Those sorts of things aren't always accessible, though. So for someone who's listening to this, and many of the people that do listen to this are healthcare providers, do you have any advice to them if they're trying to support patients who might be dealing with these challenges about how to make it a little easier for them, since we don't quite yet have the level that we need in terms of access?
Yeah, thanks, Krista. I mean, it's a gradient, right? So I think most of us, that I will call the mainstream or standard healthcare providers, um, practices are relatively unpatient centered, and kind of, as I said, work well for us. But they're usually very highly protocolized. These are our referral criteria. If you don't show up, then you get a 1 or 2 strike policy and you're out. We all have all these strict criteria. As you said, some of the programs that I do are we try to move as far as we can to the other end of the spectrum. And I run a program called the Diabetes Mobile Clinic, which really strives to be a one-stop shop where people can come and show up and be seen by a diabetes specialist, a diabetes nurse, have their foot examined, have their eyes screened, get their blood work and their kidney tests done, all right, literally in the same spot that goes to their front door, essentially. So, that I see as being quite patient-centered, at least as much as we can be. And as you said, that takes a lot of resources and effort, and maybe we're not all able to do that yet. But I think there are steps we can make to pivot our current healthcare practice to be more patient-centered. With small things like having more permissive appointment guidelines, right? So it's not uncommon in my clinical practice, and this is the one in the hospital, my hospital clinical practice, that my medical office assistant will message me in the middle of my clinic day and say, so-and-so patient was supposed to see you at 10 a.m., but they can't make it now. So they're wondering if they could do a phone visit. And most 99% of the time, I'm happy to pivot and say, yes, I'll call them instead. Or so-and-so missed their appointment at 9, it's now 2 p.m. Would you squeeze them in at the end of your clinic day? I realize that we can't always do that, but most of the time I'm able to make those things work. And my staff is always surprised. They say, well, the other doctors don't do that. They say if they miss their appointment, they have to rebook in 3 months from now. But that's a small tweak for me, right? Yeah, maybe it makes me stay an extra half an hour in my day, but I was probably going to be there charting anyway. And instead I moved my charting to when they didn't show up. So it's always possible to flex, and to be a little bit more patient-centered. But I think we have the inclination in healthcare to be very cut and dry. Nope, this is not the way. Nope, that person's A1C isn't quite high enough to be part of this practice. It's time to discharge them. There's always this push for efficiency and this push for more patients and more billing. And I think we have to realize that the more we get into that paradigm, the more we are, I think, doing a disservice to our patients, and specifically the patients that face a higher burden of social disadvantage.
Yeah, it's really fascinating when I hear you talk about these things, because I think oftentimes we do look at it from a point of privilege. Like I look at everything, I work with endocrinologists. All of my healthcare needs are pretty easily acquired because of the privilege I have, because of the role that I have, and the circumstances of my life. And so thinking about those things through the lens of people who don't have that privilege can really be so you know insightful. And I hope that many people listening will feel the same way. It also makes me think a lot about policy. And you spoke about policy earlier, and I really want to flip back to that, because so much of the structural inequities, the real systemic change has to come through policy change. And so I wondered what you have been doing in the area of, advocating to government, or in the area of talking to governments about the programs that you're running that are working really well, or things that we should be considering.
Yeah, policy change is never easy. And what I've come to learn, I think about over the last 15 years that while I've been working in policies, I used to really have a perspective that if we could generate higher quality evidence, that governments would be more inclined to make favorable policy changes. And we just need more studies and more science and more evidence. And what I've come to realize is that's really a small piece of the pie, and that governments are generally interested in evidence, but they're certainly not bound by evidence. And I would say they're also not compelled by evidence. So we can do the best quality study out there, But that's not really their mandate. They're not responsive to the scientific community. Governments are generally and responsive to electors and to voters. And so it's really what the public is demanding is what governments are responsive to. And so it's hard to change, to move the needle in policy without thinking about how do we sensitize communities and people at large to the issues that are being faced and change people's minds and hearts on issues. And so that's where I come back to we do need that kind of hard scientific evidence in terms of percents and rate ratios and dollars and costs. But really, I think we need people to understand the lived experience of people. And I think I generally operate from the perspective that most people are good and decent and kind and empathetic. When those qualities are lacking, in my experience, it's usually because people don't have the experience. People have never met somebody or dialogued with somebody who's had these experiences. And I'm very privileged in my life, in my clinical practice, but also in my research, to talk to people who've had a very broad range of experiences that are very different from what I grew up with as a very privileged individual. And I'm exposed to a lot, and that exposure is what's helped me to change my perspective. And so I like to optimistically think that if we as scientists and science communicators can think of ways to get these stories out there and to help people understand what it's like to live with food insecurity, rather than just how many people is it, but what is it like, and who are these people? These are your neighbors, these are your friends, these are your family members that are struggling with this. I think that increases empathy, and that will ultimately, I believe, change the policy milieu or environment that we live in, rather than just trying to hit policymakers with randomized controlled trial evidence. Because in my experience, that's not enough, because that's not who they're responding to. And if their constituents want something different, then that's what they're going to focus on.
Yeah, and it's such an important point because I think that if people knew what it was like in the shelter system, if people had even been to a shelter, sometimes I think even just the experience of being there for a day can really change your thinking around some of these areas. And so I'm going to ask a question now, and I will say to the audience that's here live with us today, if you have a question, please do put it into the chat because we will answer those after. But a question I often have is I tell people all the time about all the things I've learned from you because there are many, and you have had a huge impact on my understanding of these issues. But I wonder about your aha moments. You work with some incredible people. You have the chance to have these wonderful discussions. Are there any times where, you kind of had that moment of like, oh, that really shifted my perspective?
Yeah, good question, Chris. It's been a long journey for me as well. And I mean, like I said, I think if I look back to the environment I grew up in, I mean, you mentioned I'm a professor at the University of Calgary, and I actually grew up in the city of Calgary as a middle class white kid in Calgary, which in most cases means you grew up in a rather conservative political environment, where in my family, there was a strong emphasis on the idea of kind of agency and on personal responsibility. And, if you don't make something of your life, then that's of your own choosing. And people who, and this, again, not just from my parents, but the whole community, the environment I grew up in was very much of that mindset that if you want to be successful, you can be successful. And I think that was relatively true in my case because I was given every opportunity to get a university education and live in an environment that was relatively free from adverse childhood experiences and all those things. But it wasn't until I was a little bit older when I started to have the experience of interacting with people who came from a very different background from myself. And I lived for a time in South Florida in Miami and lived in the pockets of Florida that were inhabited by immigrants and refugees from the Caribbean, from Haiti, from Jamaica, from Cuba, and was really close with the Haitian immigrants in that time of my life. And to hear their experiences and the things that they had been through in their life and were struggling with as newcomers to the US, it really shook my paradigm of this whole view of if you want to make it, you can make it. And it's all kind of on your shoulders. And it's the first thing that really sensitized me to structural and social disadvantage and the fact that it's easy for those in privileged positions to exaggerate the agency that people have. But when you've lived in the shoe, lived in the position of not having choice, that's a very different story. And so for me, that was probably the biggest aha moment of my entire life, was interacting with these people and realizing that the whole kind of foundation on which I kind of assumed the world operated was a very different world than the one in which these folks lived. And that's continued to permeate my approach to work, in a clinical sense as well as in a research sense. So that's probably the biggest one. And then the other one I mentioned earlier was when I started asking people what their priorities were and what they thought we should research as a scientific community, and really having a very different answer than the ones that I would have come up with. And we did a study about that as well, and kind of asked patients and healthcare providers to prioritize the things they thought were most important. And some aligned, but there were some really clear areas of divergence where the people with lived experience had a very different perspective on the things that affect their day-to-day life. And I think that was what was has been really striking to me as well, working in this field, is that as a provider looking after patients or providing care to patients who live with chronic diseases, and especially as a specialist, I see people sometimes once every year at most, maybe once every 3 months. That's kind of the most frequent visit. And I feel like I get to know people pretty well. But when you're the person living with diabetes every second of every day, and struggling with, when I eat that thing, my sugars go crazy, and I don't know what to do, and I don't have money to pay for testing strips, and I can't eat well, even though Dr. Campbell told me I need to eat better. It's a whole different ballpark when you're living with it every day. It's a totally different ball game. And for me, that's really eye-opening to realize that the day-to-day experience of living with a condition is very different than being a scientific, academic, medical expert in that condition. Very different kind of expertise. So that's been a big eye-opener to me, is to realize that people's lived expertise is generally more valuable than my expertise, having gone to school for 10, 15, 20 years. That pales in comparison with the expertise generated over a lifetime of living with a condition.
Yeah, that is so powerful. And I think such a wonderful place for us to sort of end on, unless there's something pressing that we've missed that you want to get in. I do have a couple of things that came in from the audience, so I'm going to ask those very quickly before I let everybody go back to their day. And one is, where can they find Low or Home Sweet Homeless?
Yeah, great question. So Home Sweet Homeless was published in the Canadian Medical Association Journal. So it was published in 2020. So you can Google CMAJ Campbell Home Sweet Homeless and you'll find it. You can see our write-up on it, but also in the appendix, you'll actually see the raw images and the narratives from our participants. So that's where you can get the whole photo exhibit there. And in terms of where to find Low, it's a great question. It is not yet widely available. It will be in the coming months and years. In the next months, I would say we'll be putting it on a platform to make it more widely available. But for now, you can find information about it on our website. Our website is calgarydac.ca. And /low will take you to the trailer and the information about the film, and a way that you can request a screening. And we do put on screenings for groups, both workplaces as well as public screenings in certain instances. So if you've got a group of people that want to see the film after seeing the trailer, we'd be happy to make that happen. So please reach out, and there's a contact us form there. So calgarydac.ca, that stands for Calgary Diabetes Advocacy Committee, which is our group's name.
Amazing. And I highly recommend anyone watching, please do take the opportunity to see it if you can, because it is such a great film and it makes such an important point. And thank you to Rana for putting that in the chat here for those of us who are in person. And the last question is really, is there anything like a training program or anywhere people can go for more resources if they're interested in learning about working with people who are experiencing homelessness and diabetes? Is there anything you recommend?
Yeah, great question. There's no training program yet, but it's in the works. My team is actually in the process of creating an online training platform using the backbone of Low and Home Sweet Homeless. So stay tuned on that. We're working closely with collaborators at the Centertown Community Health Center in Ottawa. And we hope in the next 6 months to have an online training resource platform where you can go and become certified in one sense or another in how to provide culturally sensitive and trauma-informed care for this population.
Amazing. Well, I will definitely be looking out for that. And I know that many of the people who are watching or listening will also be. So I want to thank you for being here with us today. As always, this was a wonderful conversation. And I want to thank everyone who joined us live and all of those who are watching from afar. As always, we will be putting this on YouTube. So many people will be watching it there. And if you have not already become a member of the Type 2 Diabetes Network, please do consider that it is absolutely free and you will get information and access to events like this and many others. So we will have that in the comments below or in the description below our video, as well as for those of you who are here today, Rena has put that in the chat. So thank you to everyone who joined us here today.